Good morning, everyone. My name is Chad Scott. I'm with the Division of Medical Assistance Programs, and I'm joined here with Lisa Holmes, who's also with Medical Assistance Programs. Today's webinar is titled Medicaid Reimbursement for Behavioral Health Residential Treatment Services. We'll check to see if everybody can hear us from raising there. We'll go ahead and make sure everybody can hear us and that everybody's not having any issues. Okay, so what we will cover today, we'll discuss the types of Medicaid services that are reimbursed in residential treatment. We'll discuss the prior authorization requirements. We'll discuss the prior authorization approval process, which includes a review of the clinical documentation, the locus, and we'll introduce and discuss the level of service inventory for residential treatment. And then we'll go over any questions and we'll discuss resources. Looks like we already have a question. Okay, sounds like everybody's on board, so we'll go ahead and get...
And someone was asking about the PowerPoint, and we did email that out.
Yes, the PowerPoint was emailed out prior to the webinar. If you didn't receive it, we'll send it out afterwards also. Okay, so the types of Medicaid services funded in residential are basically comprised of 4 different Medicaid benefits. There's the 1915I Home and Community-Based Services Habilitation Benefit, which comprises home-based and behavioral rehabilitation. We fund state-planned personal care in residential programs. We fund state-planned rehabilitative mental health services. And we fund in 1915I home and community-based services psychosocial rehabilitation. And for the 1915I services, individuals must meet specific eligibility requirements under the 1915I. If you're interested in that or not familiar with that, you can go to the link there below, and it talks about the 1915I plan and what the requirements are for eligibility. So one of the first services that we fund are called personal care services. Personal care services basically are a range of assistive services to help people with things like ADLs and IDLs. It can be hands-on assistance, or it can be skills training or supervision. And this is the most common service that people in residential have received historically. And again, this just talks about personal care services and that they address activities of daily living and instrumental activities of daily living. And that kind of gives the definition of what those services are. And this slide covers personal care service providers. So to receive reimbursement for Medicaid for state-planned personal care, paid provider of facility-based personal care must be licensed by the Addictions and Mental Health Division as either a secure residential treatment facility, a residential treatment facility, or a residential treatment home, and must be enrolled with the Division of Medical Assistance Programs as a Medicaid provider. So personal care is used to fund SRTF treatment, RTF, and RTH care. Medicaid reimburses for facility-based personal care on a per diem basis, also known as a daily rate. In most cases, the rate paid each provider is the same for each recipient, and the rates are based on the cost of the program and are usually unique to the program's operating budget. And Medicaid pays for personal care services using the code T1020, and those services are coded with the HK modifier. And the other service that Medicaid reimburses in residential are I-Plan habilitation services, and this is a relatively new service, very similar to personal care, and is being used in the majority of programs now, except for the secures. And there's 2 types of habilitation. First type is home-based habilitation. This is a service that's provided in order to assist an individual to acquire, retain, or improve skills in one or more following areas, such as assistance with ADLs, on to things like socialization, adaptive skills, or any skills that an individual needs to reside successfully in their home or the community. And the second type of habilitation is referred to as behavioral rehabilitation. And these are services that are designed to help an individual attain or maintain their maximal level of independence, including assisting them to accept their current residence and assisting them to prevent any unnecessary changes in residence. I think we have a question there. Anyone? Okay, no new questions. So home-based habilitation is a service that's based on individual assessment and delivers a combination of IADL, ADL supports. It can be used to fund staff to support individuals' recovery. It can be used to provide assistance in obtaining non-medical transportation. It can be used to provide skill development in ADL and IADL areas. And home-based habilitation can be delivered in a community setting. It can be provided in an individual's home. But specific to this training, it can be provided in RTHs and RTFs, or programs that aren't considered secure. Behavioral habilitation can include things like behavior support, training and education to develop psychosocial skills, and things like activity therapy. And behavioral habilitation can be provided in an individual's own home or any residential treatment facility that's not considered secure. Habilitation providers are often residential treatment homes, residential treatment facilities, or for non-facility-based providers, QMHAs, QMHPs, peer support specialists, and recovery assistants can be habilitation providers. Similar to personal care, Medicaid pays for habilitation services on a per diem basis or a daily rate. In residential facilities, there's also an hourly rate in the community. In most cases, the rate paid to each provider is the same for each recipient and unique to the costs associated with operation of the program. And Medicaid pays for habilitation services using the per diem code T1020, which is similar to the personal care code, although it's modified with the HK and HW modifiers. The HW modifier indicates the service is provided under authority of the Oregon CMS 1915I State Plan Amendment. A third service that's provided by Medicaid and residential care is called rehabilitative mental health services. Rehabilitative mental health services support recipients to achieve the maximum reduction of mental disability and restoration to their highest possible functional level. These services include things like assessment, crisis services, therapy services, medication management, peer support, case management, and skills training. Often these services are referred to as the HK services. In order to receive payment for rehabilitative behavioral health services, a provider needs to be a licensed independent practitioner, such as a doctor, psychologist, or counselor, or be a provider organization who has a certificate issued by AMA. And for employees that work for a certified agency such as QMHA and QMHP, they can be reimbursed for rehabilitative mental health services. And for more information on that, you can look at the administrative rules on that. Again, this is what I talked about. So the non-paid providers who are employed by a provider organization certified by AMH, such as the QMHA, QMHP, intern, and peer support specialist, can provide rehabilitative services. And rehabilitative services can be delivered in RTHs, RTFs, and SRTFs. Do you have a question there, Ashley? So I have a question here that says, in a case where a client in an RTF needs further one-to-one staff, providers have said they cannot use 1915I as they do not receive additional funds that other funding AIM-HI is required. Is this accurate? So if an individual is in an RTF, it's true they cannot receive 1915I habilitation services from an outside provider. All the habilitation services provided need to be billed under that singular per diem rate. However, as we'll talk about later in this training, the program is incurring additional costs to meet a treatment outcome for an individual, such as one-to-one staffing. The LSI can be used to document that and can be used to request a change in rate to support that one-to-one staffing. So the answer for that is the services need to be captured under the single rate, and you cannot have an outside I-plan provider provide the service because that would be considered duplicative. I have a question here that says, how is habilitation skills training different than rehabilitation skills training? It's a good question. So the distinction between habilitation and rehabilitation is that habilitation is doing something for somebody to the extent that they can't do that themselves. So if you're habilitating somebody and you're teaching them to ride the bus, it may be that you need to take them to the bus stop and help them get on the bus, and you're kind of doing that service for them while working towards a goal.